Well, welcome to Geriatrics Grand Rounds. I see people are joining as I speak, and I am just so delighted to introduce Dr. Gina Intinarelli, who is the Vice President and Chief Population Health Officer for UCSF Health. She's also the Associate Dean of Clinical Affairs for the UCSF School of Nursing and the Associate Chief Nursing Officer for Nursing Excellence for the Center for Nursing Excellence and Innovation. So lots of great stuff. Gina is a graduate of the UCSF School of Nursing, earning her master's degree in 2005 and her PhD in health policy in 2013. And this is where I learned you learned how to be a nurse advocate. And I love the story that I read about how you became part of this, the Nightingale nurses that would buy single shares in tobacco companies so you could attend tobacco stakeholder meetings and educate people about the dangers of tobacco. And even convinced, it sounds like the CEO of Walt Disney to not show images of smoking in kids' films. So I thought that was really neat. You also have served as the clinical operations director for UCSF cardiothoracic surgery for 14 years prior to your current leadership. And I certainly know you as just a wonderful colleague who has been so supportive of geriatric and complex care programs, especially our Care at Home program, which lives under population health. And certainly just a wonderful thought leader in how you take care of, total entire populations, but also always keep what's in the best interest of individual patients front of mind. So anyways, just so delighted to invite you. And thank you so much for being our Grand Round speaker today.
Great. Thank you so much, Louise, for the wonderful introduction. Hello, my geriatric colleagues. I can certainly say that you are the most forward-thinking, wonderful group of people that I have ever had the privilege of working with. I remember, as Louise reminded me, that when the Care at Home program has been an amazing program and was really is on the forefront, and we all fought hard to keep it and have investment in it. And at this point, it is just such a key program for managing our really vulnerable older population and doing amazing work. In fact, I just left the Chief Operation Officer's direct report meeting, Sheila Antrim, to go over all of the wonderful programs we have and really make it clear that, that the Care at Home program and many of the programs that we do in population health to manage our most vulnerable populations are not always transparent to the work that we're doing and what we're doing to help those patients. So thank you for everything that you're doing as a team. And what I wanted to talk to you today about was really about what we've been doing in population health, especially around Medicare with our alternative payment models. I just saw some data recently that said that one of the reasons that ACOs and alternative payment models have a hard time being adopted is that many clinicians don't understand them. We've been working in the same model of healthcare since the mid 1800s in a fee-for-service environment. And there's a real push to change the way we do payment models, especially in Medicare leading the way. So I thought I'd take the time to just show you a little bit about what these models are and what we've done at UCSF and the lessons we've learned and some of our successes and even some of our failures. We learned a lot from being in the Medicare ACO. So without further ado, I'll go ahead and share my screen and we'll start the presentation. And I'm going to get through this in about 40 minutes or so that we have time for questions, as there may be many questions. And I may stop at certain points to just see if there are questions in the Q&A or chat, or would rely on Louise or Maxine to help maybe curate some of the questions if they come in. Okay, so I think everybody can see my slideshow, so let's get started. So thank you so much for having me. So I think everyone received the objectives, but really wanted to go through the basic financial concepts and operational considerations of alternative payment models. What are they? Why are they different? How is it that we need a whole Office of Population Health to help us think through this? Understand and apply what are the best practices that we're doing for care management strategies for older adults in these models, and really to share with you some of the data and lessons learned that we've had with the UCSF experience in our Medicare ACO and some of our other Medicare alternative payment models like Medicare Advantage and our bundles program. So this is something that I feel like I'm preaching to the choir, and I still feel like the resounding is not loud enough still. I everywhere I go, every part of the organization that I'm at is that by 2034, we will have more older adults than children. And that because all adults over 65 are eligible for Medicare, many of our and many of those are our poorer adults who are eligible for both Medicare and Medi-Cal. We really know that this explosion in this older population has a lot of good things happening, where people are living longer and living healthier and really having very wonderfully productive lives. However, this does translate into more costs for the Medicare program, which is why Medicare is really working diligently on thinking through and trialing different models. Right now, all of these models are mostly mandatory I mean, mostly voluntary. And we'll see what happens with, there's a couple that are mandatory at this point. And many of you probably already know this as well, that 15% of the total federal spending in 2018 is expected to rise to 18% of our total federal budget just for Medicare. So Medicare benefits for A, B, and D, these are the costs in 2008 and 2018. Again, we have a population that's living much longer, and you'll see from some of the frequency distributions we have on our Medicare ACO population, where we were able to do a lot of population health analytics. It's just amazing how many people are living over 100 these days. So why is payment changing? So one, it's because of the cost and the size of the population that we have to think about how we might fund and pay for the costs of healthcare for these individuals. Fee for service is what we've been doing for a very long time, where we charge a technical fee and a professional fee for every service that we deliver on every patient. And as you know, that is a complicated structure. It's based on coding your visit and sending in a bill and getting paid by Medicare. Some of that's already capitated in the form of a DRG, for example, and certainly in the forms of the criteria of the types of billing you can do for certain office visits, et cetera. And where Medicare has gone first is into this increased performance-based payment. So we're already deep into MIPS, and I'll talk a little bit about that, but MIPS is really addressing the physician or the professional fee side of the Medicare equation. So there's a technical fee and a facility fees that get charged through Medicare Part A, and then there's the professional fees that get charged through Medicare Part B. I might have that mixed up. But we've already seen that it's really required that we meet quality, operational, and cost considerations. And if we don't, the physician Medicare fees for physicians are penalized up to quite a bit of a percentage. And I can show you a little bit about what's happening at UCSF. The other areas are really tackling the alternative payment models, which are bundles, ACOs, Medicare Shared Saving, and Medicare Advantage, where we look at the total cost, both professional and facility fees, and you are held up against a cost target for different patient populations. And as you manage these patient populations, you typically work with Medicare, they give you the claims files, and you're able to understand where all the spend is. And depending on the model, is really determines your level of risk that you will, the financial risk that you will take on as an organization or as a physician group. And then Medicare determines the cost targets based on the risk profile of the population that you're managing. So I'll explain that a little bit more. So the Affordable Care Act, which was really exciting, and one of the reasons we formed the Office of Population Health, was created specifically to stand up an innovation center. And the thing about the innovation center, the CMMI, is it gives us the opportunity and gives Medicare the opportunity to test these models without having to go through the entire legislative process. So we're able to make changes to some of these programs based on feedback from the participants, so that it doesn't have to go through the laborious, federal legislative process. And really, the goal was, we thought by now that we would be meeting these goals, that 85% of fee-for-service were tied to quality or value, and that we had 30% of people in alternative payment models. Due to changes in administration and then some of the early learnings we've had through the payment models, we haven't quite met those goals. And obviously, there have been other things recently that have been taking up the federal government's bandwidth, other than focusing on payment reform, but I think it'll be back. This is actually a really handy framework for thinking through the different models. So category 1, just to put it in perspective, about 93% of all UCSF revenue comes through fee for service, both Medicare and commercial, obviously. And only about 6 to 7% of our total volume is linked to any sort of alternative payment model. Category 2 is this fee for service linked to quality. So these are things like care coordination fees, pay for reporting, bonuses if you meet things like readmission reduction, MIPS reporting, some pay for performance for quality. Category 3 are the alternative payment models built on the fee-for-service architecture. So what that means, for example, is when you are in a Medicare ACO, you're still doing all the same administrative tasks of how you would bill in a fee-for-service, but you have a contract with Medicare, and you are managing a certain number. In our case, it was 10,000 patients to a specific cost target over the course of a year. And you would share in that downside risk if you entered into a downside risk program with Medicare, which is what we did. So, and I'll talk a little bit more about that. And again, with bundled payments. So the way that that works essentially is that we agree with Medicare to hit a certain cost target over the course of the year. Nothing changes in the way that we administer or take care of the patients as far as billing, et cetera. And then those things are reconciled, kind of like an accounting record, where we go back through and we assess risk and total cost, and did we meet our targets? And if we didn't, we owe Medicare money. If we did, we share in the savings with Medicare, those projected savings. And then finally is population-based payment. So these are really areas where this is things like Medicare Advantage, where you have a certain number, you have your entire Medicare population who is signed up, usually through a health plan that you, and Canopy, our health plan, does have a Medicare Advantage group of patients. And based on their risk coding, which I'll show you a little bit more about, many of you probably already know this, but based on that, you get a capitated amount to manage that patient, and that's it. And it's and if you manage the whole population well, and you really take care of them and keep them out of the hospital and in those high cost areas, then you can make revenue. If you don't, then it's basically like a business, and you lose money. So that's how Medicare Advantage at its basics works. Now, of course, there's a lot of guardrails about how you can manage these patients and what you have to offer them, of course, because we want patients to get high quality care. So this was Medicare's timeline for delivery system reform when they were first really going at it back in the early 2000s, 2011, 2012. They had all these different ACO types, all these different medical home models, all these different bundle payment models. And again, because this came out through CMMI, which is the Innovation Center, Medicare could work with us, although it was very difficult, in changing these models, because they're getting all the data back and they're testing them all. So there's many different models. In some cases, we didn't meet some of the criteria to enter into these models. In some cases, the model was so risky that we wouldn't do it. But these are all the different models. And even since then, there's been a couple others. Now Medicare has an opportunity to do direct contracting with Medicare. And then there's another one called primary care first, which is kind of an iteration on CPC plus. So there's all these different nomenclature, but just to know that Medicare has many, many different payment models that you can learn and test and do if your organization is obviously willing to take downside risk, which has been one of the big barriers, is that many organizations have been going through troubling times, just even with fee for service, that a lot of people were very risk averse and didn't feel the need to take risk. This is again just the BPCI Advanced is the bundles model. I find this model to be the most fun and the easiest, mainly because for the most part, it's for surgical patients. When the episode starts when they come in, and then you have to manage them 90 days post-acute. And there's a lot of work, as all of you know, in the post-acute space that often is not addressed or not well organized. And this really gives us the incentive to help our patients manage the transition, usually from a really serious event in their lives to the home in 90 days beyond. So I really like this model. We've been successful in this model, and I think it offers the patient really good care. And again, this is how the model works. It's pretty simple. The cost of the DRG or the inpatient stay is rolled into the total cost of the model. And then they project based on the patient's risk scores how much a 90-day episode would be. And then they will, and that's your cost target for that patient. And so basically you're managing post-acute costs, whether that's SNF length of stay, whether they go to a SNF at all in the first place, if they get readmitted, obviously that's a huge cost in a 90-day episode. And so we've really put in wonderful infrastructure for our patients to help them navigate this often very confusing and difficult time after surgery or after any sort of discharge. They have medical models as well, but we've entered into 2 surgical models. This model actually does have a lot of uptake. A lot of people found a lot of opportunity here because it was easy to administer because you kind of knew who the patient was. And these other models are really difficult in fee for service because because a fee for service patient may or may not have a primary care doc, and certainly even if they do have a primary care doc in your health system, may be seeing a whole variety of physicians that are not connected at all in their in their medical home, if you will. But this one gives us the opportunity, at least for if you're starting in the hospital, to have a place to identify these patients easily and manage them. I think I went through already how the shared savings model works, but essentially it's very similar to the bundles model, except it's for the whole year. So, and a patient who is a Medicare fee-for-service patient, if they're seeing your primary care physician at your organization, or if they are getting what they call a plurality of their care through specialists, if they haven't seen a primary care doctor, that patient is yours, meaning they're yours to manage. And then again, based on their risk code, you get what they think a projected cost would be for that patient over the course of a year. And then you're trying to manage that patient or that entire population to meet that cost target. So in 2019 was I think the biggest year for people to sign on to the ACOs, but then Medicare became really aggressive in how quickly they wanted you to move to more downside financial risk, and thus a lot of people dropped out. And then COVID was a really hard year. People just felt like they couldn't manage it. So this 2020 was a year where we saw a lot of exit from the ACO program. So it'll be interesting to see where the ACOs end up. And I'll tell you a little bit about our experience. And then Medicare Advantage I already talked about, which is basically, it's an HMO for Medicare, which has a narrow network and covers a lot of things and why patients gravitate to it. Total Medicare Advantage enrollment is going up. And I think patients, as we see patients age into People are very familiar with the HMO model. So as new retirees age into Medicare, a lot of them want to keep that model because it's worked for them. I think secondly, it also offers, these programs are able to offer benefits that traditional Medicare doesn't, like dental and eye and access to gyms and things like that. So a lot of patients are finding that to be very convenient, and are entering into that. Okay, so I'll stop there before I go into what we're doing at UCSF to see if there are any questions.
I don't see any questions other than the
Okay.
request to have slides. They would love to get a copy of your slides, so we
Oh,
will do
sure,
that.
no problem. Okay. Okay, so let's move into what we're doing at UCSF. So first of all, just to kind of level set, why do we have an Office of Population Health? I just gave the whole background. I think well, first of all, I think it was a bit of a trend across the United States as people tried to move into these models. They recognized they needed people who were dedicated and experienced to really understanding and putting an infrastructure in place where you could ingest claims files. You could understand you're kind of sort of functioning like a health plan because you're getting total cost of care metrics. You're having to look at claims files, et cetera. So our system in our Vision 2020 recognized that we needed what we would call a high value system of care. And so that included standing up the Office of Population Health, and then also really establishing our Canopy network, which is a co-investment between John Muir and UCSF, where it is a health plan and a network, both. So those things were part of UCSF Vision 2020, and we were a part of that. Our mission here in Office of Population Health is combining innovation with compassion to transform care delivery across UCSF Health. And we have a statement for every pillar, and we have a team who deeply believes in all of these values, and we really have an amazing team. This is based on a best practice structure for how population health departments should and could be organized, and then really to give a high level of the capabilities and what we do in population health. So I'll start here in the orange part. This is just the divisional management, and this is not any different from, I think, any other division where you have divisional administration, et cetera. I think the two things that I feel lucky to be able to do is, one, participate in health system strategy and bring a pop health orientation and lens to the conversations when we make decisions about what we do as a health system strategy. And then two, we do have a very robust learning health system group, and my team has, my on the ground team has done a lot of very rigorous work to publish some of their implementation work that they have done around innovations and some of the work they've done. We also work really closely with the contracting team when we're bringing on new ACOs, and then we work really closely with the payers. That's been a very strained relationship, as you can imagine, because they look at us as being people who cost a lot and don't really do anything to contain costs. And so part of the ACO structure is working with them to have common goals, or and to understand from their lens, the payer lens, some of the things that they are dealing with, and vice versa. So we're learning a lot about each other and each other's worlds. In population health, in the green box here, we have an informatics and analytics department. We have a lot of work happening where we bring in outside data, claims files, other data from derived platforms around quality, et cetera. We have a team that's learned to really have pop health methodologies for how we report out on patient populations. We are building within Epic our Healthy Planet infrastructure. So one of the goals is for population health to help manage the governance of that, where we have ways in our Epic record to manage patient populations easier. Again, I think the larger investment could be bigger, and we're making the case for that. And then one area that is sort of nascent for us is predictive modeling, and we're hoping we can find partners to think through that with us on how we would identify, when you're managing 100,000 patients, it's good to try to hone in on the ones that you think might need the most help. Then we have our population health quality and performance improvement team. We have state and federal quality programs. We administer the MIPS program, PRIME and QIP, which are focuses on our Medi-Cal populations. We are really very committed to healthcare disparity reduction, and I can show you some work there. And then there's a lot of pay for performance quality metrics that, UCSF had formerly not been well organized around, and now we are, and because there are a lot of incentive dollars for us to go after, and we actually give really good quality to our patients. It's just a matter of having measurement expertise to be able to submit in the way that we need to. And I talked a lot about our coding support. So again, one of the things in ambulatory, and I'm sure you've been asked to do this as well. I know that you've been working with Elizabeth Askin and Avi and team, but it is critical in Medicare. And I know it's a burden, but just like the inpatient teams around CDI and capturing the appropriate DRG and MCC codes so that we can get the appropriate payment for the patient. The same thing is here, because if we don't accurately identify or show the risk of our patient populations, then we de facto in these models are not getting the budget we need to manage the complexity of the patients that we have. And then there's other work that happens here around us building an infrastructure for managing our Medicare Advantage population. And then many of you know we have a lot of hallmark programs around our clinical programs. That's the bulk of our team is really dedicated to the clinical care of the patient population. And I like to think of this as sort of the exoskeleton of care that doesn't exist in the typical fee-for-service world. So this is where, care at home falls in, your great program where you deliver care at home, but it's also disease management, clinical protocols, gap closure, care transitions, our bundle payment, care coordination, better post-acute care, pharmacy management. There's a lot of things that happen that we add sort of an extra layer of support, at least around the patients that we are at risk for. I think the struggle for us has been, we'd love to do it for all patients, but we're only resourced to do it for a certain amount. And that's kind of the sad part. And then recently, as you have probably seen, our team has also really jumped in during COVID-19 to help manage both the employee response and the hotline work. So our teams really did a lot of that. And right now that structure still lives under us. This is just to say where we are. So we started down here in fee for service. And I think I mentioned we're only about, of the total volume that runs through UCSF, only about 6 to 7% is in any sort of alternative payment model, whether that be in an ACO with upside risk only or any of these programs. So relatively for the amount of patients we see here, it's very small. When you look at something like Kaiser's 100%, they're 100% capitated on the population they serve. Or you look at a place like Geisinger or Ochsner or Partners Healthcare, they have millions of patients that they either have self-funded insurance plans or they're in these alternative payment models where they are taking on complete risk, financial risk for the patient population. So we're still in, I would say, a tiny bit of a bubble here in California where other places have really advanced many of these payment models, and huge health systems and networks are taking full risk or shared risk on many of the populations that they serve. So it really does make a difference on the infrastructure that you have to manage patients in this way, which honestly is the way we want to manage patients. We want to put more investment into primary care and wellness and the programs that we have in geriatrics, because we know at the end of the day that helps reduce costs. But it, as we all know, in a fee-for-service environment, it's hard to cover those costs. So it's really flipping the switch for us to get to that tipping point where the investment will be different. I don't know when UCSF will get there, but the good news is that we have a group of people who understand how to do it and what we would need to change once our populations get bigger. So we're dabbling in these areas with small populations, at least to learn. But we're all the way up here to capitation and Medicare Advantage because we started that vis-a-vis Canopy in 2020. And this just goes to show what has been our growth. So we've been in ACOs since July 2011. And we've been growing our population since then. And these are all the different populations. We are in all of them. So we're in Medicare, Medi-Cal, and commercial. They're very different on what you focus on, as you can well imagine. And each of the payers are very different on how you interact with them, what data they have, what their focuses are. And for even within each patient population, within the commercial plans, or even between, for example, the Medicare ACO and the Medicare Advantage, it's very different populations that gravitate to these different payers. That's been the most surprising part for me, is the sort of just the way what patients need depending on who they're signed up for, who their health plan is. And of course, that probably gets back to socioeconomic status, et cetera. But it's just very interesting when you see it at this level to understand where you have to focus at a population health level, knowing that that has to be implemented one by one. So in bundles, we're in 2 surgical episodes, major bowel and bariatric. We were in ortho, and ortho was the #1 bundles program across the United States. Certainly Stephanie and many others have helped with us in the fracture program. We made huge strides through that program and through collaboration with ortho and geriatrics to make a big difference on that patient population. But the bundles program became, they tightened the cost target so much that we were on track to lose a lot of money, and we just felt that that wasn't appropriate. And we are sending a message to CMS by pulling out of that bundle, saying you've cut to the bone now, we've done as much as we can, and we can't really get any better than we are. And so we stopped being in that program. But we are in GI surgery, again, very different patient population, really sick. But we've had great results. So when we look at even internally for orthopedics and major bowel, you know, we worked on care redesign. We were able to actually lower length of stay pretty significantly in these populations over the course of just 8.5 months by the focus on the continuum of care piece. And then the readmission rates are really the startling piece here. So with especially with major bowel, we were at a 35% readmission rate in 90 days for those patients, and we were able to lower it to 14% in 8.5 months. The orthopedic program here just represents the last year where we were really cutting it down to the bone. We had already taken the readmission rates down really low. And then what changed here in the orthopedic bundle is many of the knee surgeries they were in the baseline here as inpatient, went to outpatient. So it really changed the acuity of the patient population that we were discharging and what we were being counted for readmission rates, if that makes sense. I think I already went through this, or this is a little bit out of order, but this is our Medicare Advantage in the Bay Area. So nationally, it's about a 34% penetration. There are many areas that have much higher rates than this, like Florida and Texas have some pretty high rates of Medicare Advantage penetration. In the Bay Area, we're a little over 40%, and that is mainly due to Kaiser. So Kaiser is the main responsibility. They have the biggest Medicare Advantage plan, and Kaiser does a good job in population health. They do a great job, actually. And then just to describe our Canopy, how this Canopy works, many of you have heard of it, but Canopy Health is we are an investor as a health system. We are an investor with John Muir in this company called Canopy, which is a network for our health plan. So we have our own health plan. So if you have blue and gold, chances are you're in the Canopy network. And what that provides is a huge group of payers outside of Sutter, providers outside of Sutter and outside of Kaiser that you have access to in the Bay Area, with UCSF being sort of the anchor academic system as part of that network. And then with us, with Canopy, we also are we are a dyad partner with Hill Physicians. The physician group, the UCSF physicians are also Hill Physicians, and Hill takes the risk on the capitated Medicare Advantage. So either way, we have to have really good performance in our Medicare Advantage because we are at risk in both things. One, as an owner in a company that we're trying to get to succeed, And secondly, because we actually have in our contract with Canopy, shared financial risk in the patient populations that we manage, which is our blue and gold population and our Medicare Advantage population. So this is an example of why, if you have been being asked to think through, how you document your problem lists and throughout the year for your patient populations. This is a very good example, and this is a real example of a 98-year-old dual eligible patient who this was his only risk factor, that he was 98 years old and dual eligible. So he had a score of 1.077. When the patient came in, but not all the HCCs were addressed, and these were all of his problems, we were able to get his score to 1.695. But when we looked to say, okay, if we were to have documented all of the things that people took care of with him throughout the year, which were all of these problems, his score would have been 2.79. And so what does it mean to an HCC score? So an HCC score has twofold, and I may be telling, there may be experts out there in the audience more than me, but the HCC score translates to a risk score, and then it's called a RAF score. And the RAF score is really where Medicare takes that. It's a multiplier based on a normalization of 1, and that really is your capitated payment. So had we not done this for this patient, we may have gotten, let's just say the capitated payment for this patient was at 1.077, 15,000 for the year would have been our budget to manage this patient. Had he had all of these things appropriately documented and sent to Medicare through the claims files, his HCC score, which is his real score, would have been almost 2.8, which would have effectively almost tripled the budget we would have to manage that patient. So you can see how important it becomes as you take on these Medicare APMs. Not only that, but for us, when we also want to say, oh, we have a really sick population, UCSF says that a lot, but we really can't prove it on paper because most of the time we don't have these risk scores to actually make that argument, both with our commercial and our Medicare patient populations. So this is why there's a big effort right now for us to focus on the Medicare population. And you've probably seen some of the BPAs and things. And this is what we're trying to get to, is to really set ourselves up for when these do become mandatory, that we're setting ourselves up for success, that we're getting the appropriate credit, both from a risk standpoint, when we look at our outcomes and around any sort of quality outcome or patient outcome, that we take the risk of the patient into account. And then that also translates to how we get paid for this patient population, or how we will get paid for this patient population. And we're sort of bringing up the rear of all the other UCs have more mature programs than us. So we've been learning a lot from our sister campuses, and we have finally invested in some infrastructure to help improve our risk scores around the Medicare population. And then, when we think about, and we already kind of talked about this, but the things you need to manage these populations is you do need an analytic infrastructure, both to manage the claims, but also to constantly look at the data coming in. There is so much data coming in on these patients because everyone is managing them. We have a social worker putting in something, someone from the ED, all the data that comes into the EHR. We should be really leveraging, given all the time that everyone has to do all that work. So we really need to be better at using data within the health system, within the EMR, to help us better manage these patients and identify who's most at risk, so that we can get to that nexus of getting to them before something happens. We really want to be more proactive. And then, of course, care management programs, adding that extra layer of support that we just can't have in a fee-for-service model. As you know, with the Care at Home program and with the other programs that you have, how important it is to really have extra time and extra people to help manage the most complex and vulnerable groups of our patients. I've already talked about the risk coding infrastructure. And then you really need the clinical leadership and provider engagement. People need to understand how this works so that we can prepare ourselves. We are preparing ourselves, but I'm I don't know when the future will be here, but it seems to be coming more and more rapidly. One of the reasons that I get concerned is that we know that as soon as Medicare makes some of these things mandatory, bundles may be the first to go, that the other payers will do the same thing. Right now, again, everything is voluntary, but we know that the payers are organizing themselves to follow. In fact, many of the leaders of the commercial health plans are the ones who are writing these programs for Medicare on how to implement them. So these are, we know that our commercial groups will follow. And I think that over the course of the next 10 years, we will see a rapid decline in fee for service as they chip away at some of these models that we're talking about here. Okay, so I'm just going to spend a few more minutes so I have time for questions, but this is really our operating model in population health for our clinical interventions. And we really put primary care at the center, although at an organization like ours, primary care, our own primary care is often not the center for the patient. The center for the patient is all the specialty care that they're getting. But the goal for us is to focus on two main areas. One is how do we prevent admissions in the first place? How do we keep people safely in the home? What kinds of extra support do we have to help them manage, to do self-management? And then these are some of the areas we focus on with the older adult: mobility, cognitive impairment, social support, really focusing on goals of care and care coordination. We think those are hallmarks for all populations, but especially for the older population. And by focusing on those are often, as you know, those are often paired with the chronic disease that the patient has, which makes their chronic disease even harder to manage when any of these particular extra, if patients have any of these problems as well. So while we feel like UCSF in general does a great job of managing the chronic disease through the treatment plans, we don't think we have a good infrastructure to be managing this. Certainly in geriatrics, I know this is a focus and something that you're expert in, but in general, through the health system, this is not an area that we focus on. So our team really tries to focus on these. And then so that's part of the front end of trying to not get patients to the hospital in the first place. And as you know, that's a silent metric, because if it never gets, because the hospital seems to be the center of everything. If they don't get to the hospital, no one's even really recognizing what you do to keep them out. On the other end, we have our readmission prevention. And so that is, that's just, again, that's just to me, that's just a temporal construct, because the patient got discharged and at some period of time, you call it a readmission. But again, it's really doing the same things, but on the back end with the added layer of, patients are typically recovering from something or have had an exacerbation, and you really have to maybe manage them more acutely in this time. So those are the areas that population health focus in. As you can see, house calls really is in the middle of having you do both of those things on both ends, and we know that. Okay, so I won't talk about that. But let me just show you a little bit of what we've been able to do. So when in the Medicare ACO, this is an example of where we got our expenditures for, this is kind of the cool thing, is you get to see what Medicare spends on this patient population through all sources. So when we looked at our end-stage renal disease Medicare patients, we saw that in Q1, they were spending, each patient on average was costing $140,000. The target, based on our risk, don't forget, this is what sunk us in this, is that our patients weren't appropriately risk coded. So, but our target to managing this population was $100,000 a year per patient on average. And as you can see, over time, we did a good job. The team partnered with, the dialysis team and really worked hard to work on these things. Depression was huge in this patient population, and we worked hard on that, comorbid conditions, care coordination, and we made an impact. But as you can see, it was really hard to get down to the target that Medicare set for us. And that was mainly because we went into this program without appropriate risk coding of our patient population. This is another example of where, and I think I think Jay now is working with you all because you're moving into this space as well, being practitioners in our skilled nursing facilities, but it's so necessary that our UCSF patients get UCSF caliber care in our skilled nursing facilities. So as a model, we hired a nurse practitioner to follow our patients. And again, these are the Medicare ACO patients. We were able to go from a baseline readmission rate of 20.2 and a length of stay of 27 down to 15.5 and 20, just by having one nurse practitioner putting in protocols, seeing the patient, managing them. So it really made a big difference for this patient population. And that's kind of the neat thing about the Medicare patient, is just a little bit of love, and they really respond well for the most part. It's just that we're not putting that love out there in any organized way as far as a health system and putting the resources in to do it. But this model helps us get those resources to do it. Then we have outreach and health coaching. So we have a bunch of navigators that really work on, all of the different health screenings, wellness, depression, advanced care planning. We've had a partnership with Rebecca and her team around advanced care planning. So we love partnering with you and hope that there's more opportunity to do that. But we feel that we have good models using technology. And another hallmark of population health is really using an interdisciplinary team, where really having the right person working at the scope of their license doing this work. So we've had a lot of success using navigators in this space, and it's been wonderful. It's a very diverse team that has really become quite expert at the work that they do. This is just an example of more of our pop health methodologies, where we really want to use where it makes sense to use technology. And when I talk about technology, I'm talking about a phone, I'm talking about an automated phone system, but we actually published showing that we were able to, so the data here is on top, it's one panel manager using an automated call system to two panel managers using a standard, they pick up the phone and try and reach the patient. So you can see the number of patients we reached was significantly more. The number of patients that we were able to attempt, reach, close, the gap closure workflow was completed, and we actually got the patient's cancer screening done, was significantly better. And we also reduced the cost significantly. So this is really achieving the triple aim here. And I hope that we can put more of these kinds of structures in place throughout the health system. The other thing that we're working on with these patient populations, and something that is great about this, again, as we try to achieve the triple aim, are we actually making a difference in quality? So you can see here over time that there are spots where we've improved, some areas where we have degraded a little bit, but these are all of our metrics in MA, and where our team is working on making sure that we're closing these gaps and reaching out to these patients and making a difference in these metrics. Okay, finally, we were in an ACO, so I wanted to tell you a tiny bit about what happened in that ACO. So the way that it works is you have a fee-for-service population. They're assigned to your ACO based on either they're getting primary care here or they're getting the bulk of their care here through a specialty. And when you look at our population compared to all ACOs, it's probably not surprising that our aged non-dual population was 65% compared to the national average of 83%. Our age duals, which are the Medi-Medi, made up 20% compared to 5%. When you look across all ACOs, we had many more disabled, and our ESRD was about the same. So so we always say we get more complex patients, and this actually shows that we did. This is our enrollment through the Medicare ACO, how many patients were attributed to us when we were managing this ACO. This is just the age distribution of that, this last group of 10,000, just to kind of look at, and I'm sure none of this is surprising to you all as geriatric scholars, but the age distribution, because we had so many disabled, there was quite a few people who are of Medicare, are on Medicare, but are not of Medicare age and are actually really sick in a different way. A lot of these patients had really psychiatric, substance use, a lot of really significant pain and chronic conditions. And then you can see we had a lot of people. We had 10% of the population was over age 85. And these are just very different cohorts of patients. And as you know, as experts, very different things that you're managing and focusing on for the most part with this patient population. And you can see some more demographics here. When we looked at, their comorbidities, 83% of them had some cardiovascular disease comorbidity. And you can kind of see 19% had diabetes, 18% had asthma. And these are not mutually exclusive. Many patients had many of these together. Fair number of patients with cancer. And then I think, not surprising, but interesting to measure that, this is a population with, significant depression. And as you know, we are not addressing that in any, I would say as a system, not in any high quality or organized way. We're getting there, but there's way more need than we have capacity to manage. So we're doing our best on that. So why did we end up getting out of the Medicare? It's just what I said. It's, first of all, we had a lot of specialty patients that weren't based in primary care. The churn was really high, meaning every year we would turn over about 35% of the patients would no longer be coming to UCSF, and we'd get new ones in. So it's really hard to manage that kind of a fluctuation year to year. Secondly, as I said, our coding didn't really reflect the true complexity. So we think our cost targets were significantly off because our cost targets were based on risk coding. And then finally, CMS does some very interesting maneuvers, I would say, financial maneuvers, about they're trying to do a good job by getting rid of the patients over the 99th percentile, but patients between the 75 and the 90th, you can spend a lot of money on trying to manage the complex patients, but not really make an impact. So we learned a lot about going after the sickest of the sick, even though those are the ones that, at least from a financial perspective, don't really pay off, but obviously from a patient quality perspective, often do. And then for Medicare Advantage, which is what we're in now, I won't re-stress risk adjustment, really helping patients understand the primary care oriented model. So in some ways, MA is easier because you're very much partnered with the primary care physicians, and we work with the specialists, but the primary care doctors become really important. They're always important, but they become really important in this model. Care management, again, we need dedicated primary care leadership support to really understand this model and help us, manage to this model. Utilizing the preventive visits like we should to identify high-risk conditions and getting them into complex care. And then finally, even though we think we're pretty sophisticated, we could get much better with the analytic infrastructure. Part of the problem with the Medicare data is it came in regularly, but it is hard to manage, and there has to be some level of expertise. So we looked at platforms and things are expensive. The other part was just scale. 10,000 is like the very minimum you could probably do this with, and fluctuations become really great and costly if that's the case. Okay, so I'll stop there. I know that was a lot to digest. I hope that was helpful, and happy to take any questions.
Terrific. You have lots of questions here. I'm going to see if we can get to, we have 4 of them. I'll see if I can get to them all. So the first question is, how is the health equity factor or the lens of health equity included in the UCSF Pop Health work? And are there specific goals or outcomes intended each year?
Yes, that's a great question. So first of all, and I didn't show that because I was focusing on the payment reform, but all of our quality metrics we routinely run through health equity methodologies. And so, for example, a couple of things we're working on we're partnering with is, for example, advanced care planning in the Latinx population for discharge. We're partnering with the teams on the inpatient to help with that transitional work. We are working with primary care around hypertension in the African-American population, and we've actually almost closed the gap in 1 year. So that is amazing. We're working on all different areas because we work across all different areas. So like exclusive breastfeeding for the Medi-Cal population, depending on how you slice and dice health equity, whether it's by payer or by language or by race, ethnicity. We look at all of those factors. We've done a ton of work just recently on the vaccine work for populations that are disproportionately affected by the digital divide, et cetera. So that's actually one of the best parts of our job, and everyone is very invested in that. And in fact, everybody in population health has a healthcare disparity goal as part of their personal goal to achieve an outcome in.
Fantastic. The next question is, I've heard the transition growing pains and adoption of alternative payment models described as the two canoes issue. You have a foot in both canoes. As systems move from fee for service to other alternative payment models and respond to different financial incentives, what do you see as particular challenges and opportunities for UCSF and the geriatrics clinical services in serving our older patients given this challenge?
Yeah, so it's a very good point. And like I said, there comes a tipping point. It usually is around more than 50% of your volume is in some risk-based contract, that you'll see the flip in the investment structure and where we end up investing in the kind of care that we give. As a tertiary quaternary academic medical center, we'll probably never get away from, and we shouldn't, this is where we excel at, is the specialty care fee for service that'll always be there. But I do think as we grow a network and we add more patients to the network, you may see that through Canopy or others that we'll be taking more and more populations under full risk. And everybody calls it full risk, but I always say that there's a reason a healthcare payment is called a premium, and it's because there is, and I don't want to say that we want to make a lot of money. We want to make enough money so that we can support our mission, pay our people, and continue to grow as a health system. We're not a for-profit health system. Everything we get goes back into our coffers, but we're not paying shareholders and things. But it is true that we're in that zone right now where we don't have enough of a tipping point that we would probably invest more than we have right now in population health. But I think as those, if Medicare moves, what'll be the big trigger, I think, for most is if Medicare moves to mandatory payment reform. And then you'll see the world change, not just UCSF.
Right. Great. Next question was about when you mentioned that when you have the nurse practitioner go to the skilled nursing facilities and just a little bit of love help those patients do much better. There was a question of what is the content of that love? What do sort of the services look like?
Yep. So first of all, it's having a UCSF. First of all, it's having someone from UCSF actually respond. So as you know, these patients get discharged from services, and whoever discharged that patient is no longer on service and they don't know that patient. So one is just having someone at UCSF who can make decisions, understands the care being given, and can actually make decisions with the providers in the skilled nursing facility. Or then knows enough about the UCSF infrastructure that can connect them back. The other things we did was, for example, to put a protocol in place that a lot of times a patient would be sent back for, a low hemoglobin or hematocrit, and they would have some symptoms of being dizzy, and they would take them back. And because we don't have a place to just give some blood, they would get readmitted for a blood transfusion for a whole day. So we set up a protocol, for example, with the infusion center, that if we identified patients who met those criteria, we could bring them to the infusion center, they could get their blood and be monitored, and then we could bring them back to the skilled nursing facility. So those are a couple of examples. I think the other example is they helped a lot with discharge planning and the care coordination, so that these patients then could be moved through the skilled nursing facility sooner.
Terrific. And just, let's see, I think we have time for maybe two more. Are there other patient satisfaction or quality of life measures that are included in the value quality equation? And how do UCSF satisfaction surveys factor into this?
Yeah. So for the Medicare MIPS program, which is the program that we have with on the Part B Medicare payments for all providers at UCSF, there is a patient satisfaction, and Medicare uses our HCAHPS. So we send two surveys to patients, both HCAHPS, which is the Medicare survey, and then we send our own questions vis-a-vis Press Ganey. So those HCAHPS surveys are reported to Medicare, and they use the survey responses from that to determine they do have an arm of patient experience in that. As far as some of these other quality and payment programs, they don't really factor patient experience in, except for the fact that you have to agree that you do certain things for the beneficiaries. So for example, that you give them, you have certain infrastructure in place to manage patients' questions or issues, but they don't really measure us on patient experience at this point, except through age caps. So we have CG caps, which is we have one for inpatient and one for outpatient.
Great. And the final question, and if anyone else has questions, you can always email Gina or me and I can spread it on. So the final question was about sort of the interaction between the Office of Population Health and primary care. And specifically, what are things that population health might be able to do to increase access to primary care? We've noticed it's oftentimes really hard to get people into primary care, whether that's geriatric primary care or regular primary care. Any thoughts on that?
Yeah. I mean, I have thoughts on how we might do it, which is basically grow primary care. I think there are a couple of opportunities through one, thinking about, we have a very, I would say we have a very physician-centric primary care. Most community-based primary cares have a lot of APPs. I think there's a real opportunity to grow access and think about how we manage those populations by using more of a medical home team approach. I think secondly, we, not that we say this outright, but primary care understands that our ACO patients have some level of priority, although that usually doesn't translate, to that actually working. I mean, conceptually, we try to make that happen. I think I wish there were ways for us to open up more capacity in primary care. It's really, really hard, but we have capacity issues everywhere. I just got an email actually from somebody who is, stage 4 metastatic breast cancer who's trying to get into palliative care, and it's a 5-month wait. So I think the good news is UCSF, everybody wants to come here. The bad news is that it's really hard not to be able to serve to deliver on the promise of access that we've made both to our partners and to our patients. So I do think that there's an awareness that there are really big gaps in access, and I know they're trying to address them. One of the things we're trying to do is to move for UCSF to really have the concentration of the most complex patients and try and, help our patients get to some of the primary care in our network. That's the best I can say. I recognize it's a problem, and I wish I had a magic wand to somehow have population health have primary care access. But we're trying. We're trying to help manage patients through these care management programs. Maybe we can answer their questions or help care coordinate that'll free up the office.
Fair enough. Well, again, just so appreciate your time with us today. You generated lots of questions, so clearly this is an area of interest. So thank you so very much. We are reached the top of the hour, so I'll let you go. But again, very much appreciate.
Okay, I can't see you all, but thank you so much, and lovely to be here. And thanks for the invitation. Okay,
bye-bye. Bye.